dive into the next session. Yeah, we're going to be recording the session. Okay, so I have the pleasure to introduce Dr. Eugenia Siegler from Weill Cornell Medical College in New York. Dr. Eugenia is a professor emerita of geriatric and clinical medicine and has done extensive work in the field of HIV and aging. She'll be kicking off our first ever training session today on navigating the Comprehensive Geriatric Assessment in people living with HIV. So I'll hand the session over to Dr. Eugenia now. Thank you.
Thank you so much. It's a real honor to kick this off, and I don't want to speak too long. I'm hoping that we can learn through the case discussion. So let's see. We can get this done. All right. You can see my slides? Great, thank you. So I only want to take about 15-20 minutes to give some background on comprehensive geriatric assessment, and these are my three objectives today. First is just talking a little bit about the challenges of providing care for older people with HIV. Then we'll talk about the basics of comprehensive geriatric assessment and finally review some screening tools and protocols. So this is sort of a basic conceptual framework of the components of health and well-being. Several points I want to make. One is that the biomedical is actually just one small portion of a patient's needs, and that we have to absorb the behavioral and existential and practical needs of our patients. The other point is that the psychosocial and the biomedical, as you all know, interact and have huge influences on each other. How do the components of health translate into domains of care? HIV management and comorbidity, occur in the context of function and geriatric syndromes, and we have to recognize that we can't address the sort of medical problems separately from socialization, access to basic supports like nutrition and housing and food. And just as important, or even more importantly, the primary care has to take into account what patient preferences are. So that translation from sort of the list of all the things we need to think about and how we provide the care is an area of active research and demonstration projects. There's another thing that I want to describe or have people think about, which is that long-term survivor is not the same as an older person with HIV. Long-term survivors can be those who have been acquired HIV through vertical transmission and maybe in their 30s, and they are aging with HIV. An older person with HIV may have acquired their HIV quite recently, and the hosts of this echo are experts in this area. So that even that term of older person with HIV or aging with HIV can mean very, very different things and describe very different populations. So we're going to talk about comprehensive geriatric assessment of older people with HIV, and one way to think about it is, how do you approach an older person with HIV? How do you assess an older person? What do they need help with? Do they need help with their basic activities of daily living? Are they having trouble walking? Do they need help with their instrumental activities of daily living? Are they able to walk and dress and bathe, but are having difficulty managing their medications or getting to the clinic? What do you suspect problems with? Executive function or their cognition? Is the family home situation difficult? Where do you begin? And the importance here is that there are many domains, but screening should be formal. So comprehensive geriatric assessment evaluates multiple domains. They start with the basic and instrumental activities of daily living that I listed on the previous slide, but here are other domains that it's important to consider. One is geriatric syndromes, medical comorbidities, nutrition, what many refer to as medication appropriateness, not necessarily polypharmacy, but are the medicines the right medicines? Should this person is this person not on a medicine that they should be on? Their social network, financial status, their living environment, affect, cognition, and then the things that are key to what patients want. What are their advanced directives? What can we do to improve their quality of life? We have a consultation program. The geriatrician performs the CGA. That's not necessarily the model that your program may want to have, but that's how we started, and I think that's how many programs started, particularly in the US, because it was geriatricians who brought their knowledge base into HIV programs. So we do a history and physical. We talk about the ADLs and IDLs. We do a PHQ-4 for depression and anxiety. We screen for frailty. Before the patient comes into the clinic, we do a FRAX to assess bone health. We ask about hearing and vision. We ask some quality of life and pain questions. Our cognitive assessment is the MOCA. We also talk a little bit about prognosis. And the other thing that I talk about, and I didn't do this in the beginning, but as I had these opportunities to spend an hour with an individual, I started to talk about goals, and goals of a goals discussion allowed me to get a sense of people's not just their goals, but also their mood, their sense of optimism or pessimism, their social networks. It was a simple question that offered a lot of opportunity to get to know the individual, and that kind of additional question it can be quite powerful. To the right is EPIC. I don't know if any of you are on EPIC or whatever your electronic medical record is. We had programmed these questions into EPIC, and it worked very well until a new version came on and we lost everything. So what I use this as a warning that it's wonderful to program an electronic medical record if you have one, but the programming can disappear as these are upgraded. And to be careful about how you want to spend your resources. So who might benefit from comprehensive geriatric assessment? And this is one of the things that can be difficult to decide. Do you have a basic screen? Do you use it? Do you make it age-based? Do you offer this to anyone who wants to discuss aging? Do you take some event like a fall or some obvious functional impairment and send those individuals for geriatric screening? Some groups do the cognitive impairment screening first and send people for geriatric assessment based on that. Other items of screening or other reasons for referral can be multimorbidity, polypharmacy, or geriatric syndromes like incontinence, or can be social reasons. You and your community advisory board can make a decision about who should be referred. So screening for aging-related problems is the first step. If you think about screening for any other comorbidity, you need a tool to identify unrecognized disease that can be easily performed, but you also need the ability to follow up on a positive test, and you need interventions that are feasible. And so the choice of the screen, which we'll talk about a little bit later, is just that first step. This is the ICOPE, and love the iCope because it gives a lot of structure for not just screening, but also for responding to that screen. So iCope stands for Integrated Care for Older People. This is a World Health Organization construct that was designed for any older individual. And the World Health Organization defines intrinsic capacity as the combination of the individual's abilities, psychological, medical, all of those capacities. And that's represented by the sort of coral line that you see on the right. The functional ability is the combination of an individual's capacity with the environment that the person inhabits, so that there are opportunities throughout someone's life to affect both of these things. What we are trying to do as clinicians is to prevent chronic conditions from worsening or from appearing, to try to maintain a high and stable intrinsic capacity as long as possible. As one's intrinsic capacity declines, there are opportunities, and this is represented by the blue line, to use the environment, to use the system to maximize one's functional ability, even as intrinsic capacity declines. On the left are the domains of intrinsic capacity. Vitality, which is nutrition, and I guess the simplest way of viewing it is nutrition, vision, hearing, cognition, affect, and locomotor capacity. And the World Health Organization manual here has approaches to each of these domains. So we can look at one of them. Here's I noticed that a number of people involved in this echo are interested in cognition. Here's an example of the iCope screening protocol for the domain of cognitive capacity. And it begins with a screen. And if one fails the screen, then there's a more formal assessment. But the assessment and management involves the domains both of medicine or of standard medical approaches like these, as well as the social and physical environment. So the reason I love the iCope is that it first gives the basic ideas for screening, but its assessment and management tools recognize that the approach to any decline in capacity is global. So for any domain, you want to choose an assessment tool that's useful in your setting. You know, what are the test characteristics? How easy is it to administer? You know, is it in the electronic record, or is there someone who's available in your program who can do the assessment? And then you have to ask, what kind of tool do you want to use? Comprehensive assessment, it can take over an hour and involves the use of multiple tools. And we certainly encourage that, but my underlying message here is just to get started with something. You do not have to begin with comprehensive geriatric assessment. So what kinds of tools do you want to use? We are encouraging the use of basic general screens. This is a tool that we modified for people with HIV based on the general iCope screening tool. And there's a QR code if you want to pull it. We changed the domains from a negative approach to a positive approach, and we asked a few more questions. We can do this over the phone. We also have had community peer workers do the screen, and we have a training program that is underway to encourage more clinics to have community workers do the screen. But it is covering all of the basic domains in the iCope, and it's very easy to administer. Let's just take a look at a few other screens that are easily available and that you can implement if you want to focus just on a few domains. This is the mini-cog. You can pull any of these from online, and it's fairly sensitive for major neurocognitive disorders. For dementias, it is not sensitive enough for mild cognitive impairment. But it's very easy to administer, and it's easy to remember in your head how to administer it. Simple screens for mobility and gait include a chair rise test, and that this on the left is the chair rise test, and this is pulled from the ICOPE manual. On the right is an example of a timed up and go, where you actually watch the person walk, turn, and come back. You can't use it with an assistive device, but it is also very easy to administer. This particular screenshot comes from STEADY, which is the CDC program for fall reduction and injury reduction. They have a lot of wonderful materials. You can go to the US CDC and pull not just this particular tool, but lots of information about gait disorders if that's what you want to focus on. There are many simple frailty screens. You do not have to do the research screen, the phenotypic screen. There are questionnaires that you can use. I use the Gerontopol on the right because it asks not just physical questions, but it asks about whether someone has a memory complaint and whether they're living alone. And to me, frailty has psychosocial components, and I really like this tool. It also asks me to decide if someone's frail. It helps me if I am, instead of just checking off boxes, making a decision based on those questions, whether I think this person is at risk. There's a pure clinical frailty scale. This is also available and useful. Polypharmacy tools don't have to be complicated. The simplest polypharmacy tool is your eyes. But there are other tools that are useful, ranging from the Beers criteria, which are just warnings of potentially toxic medications, the start-stop, which I like very much because it goes back to the question about medication appropriateness. What medications is this person on? Are they on the right ones? Not just looking at total numbers. And one can get to very sophisticated regimens that are looking not just at the names and the numbers of medications, but how many pills someone's taking a day and how complicated the regimen is. So the field of HIV and aging is evolving, and I'm just delighted to be part of this echo that's going to be looking at all aspects of HIV and aging, and I encourage you as you investigate this further to also be looking ahead to aging-related syndromes and to care integration and long-term care, because we're headed, as you do a comprehensive assessment, you're beginning to think about what this individual's needs are, and they often are beyond the medical to needs that have to be met in the community, and so pursuing this allows us to begin to think ahead about what the social needs are going to be. So how do you get started with a long-range plan? This is oversimplified, but what I wanted to leave you with. Understand the demographics of your patients. Are there specific vulnerabilities? What are the existing services and functions that are available? And most importantly, just get started. You don't have to start with CGA. You can ask your community what it is they're most worried about. So your screens don't have to be comprehensive, but the program should be formal, and your screens should be formal. And then creating linkages with outside organizations or educational programs. So I'm going to stop there. and I look forward to your questions and to the case.
Thanks so much, Eugenia. That was really, really informative, and I just really liked all the kind of practical solutions you had to, implementing these type of assessments within our clinics. I think the majority of our participants here today, we have a mix, but majority who have registered are primary care physicians. So I guess my first question would be, how do you think a primary care physician can start to approach this?
That's really the fundamental question. The initial HIV and aging literature was looking at how geriatricians and primary care interdigitate, and that's a bias based on the fact that geriatricians were really interested in this and they wanted to be part of the show. But that's not realistic. And I think that question really gets to the fundamental heart. And I think you begin with asking, how much time do you have? And how much help do you have? So there's nothing magical about a comprehensive geriatric assessment. Anyone can do it. It's whether you have the time. And in the States, Medicare pays for the annual wellness visit. There's a payment incentive for us to do this. So you begin with again, how much time you're allotted, and how much help do you have? And then the third question is, what are people most worried about? So that if you have a community that is, especially, for example, I'll give an example. You may find that people, having heard about the Reprieve study, are now most worried about their hearts. You could link hearts and brains, because they are linked metabolically and vascularly, and create a sort of vascular or heart brain health program that would initiate a cognitive screen, and at the same time people are coming in and wanting to talk about cardiometabolic health. So you could start, if your patients were really interested in that particular issue, to begin a kind of geriatric or an age-related syndrome screen that ties into what people are really interested in. The other is again, if you want to do the comprehensive assessment, can you build out the time to spend the hour with the patient? Say, I know your viral load's great. I'm not worried about that. Let's talk about aging and your concerns, and can I ask a bunch of questions? And it just takes some practice. Again, that there are videos about how to do comprehensive assessment, and I'm sure, since there are geriatricians here, there would be opportunities to do some training or some practice. The third is, if you don't have the hour, what components of geriatric assessment do you want to be the one to do, and what components can be done by other members of the team? And for example, if you have a clinical office and the patient has to walk to the office, the tech or the nurse who's getting vital signs could be doing a gait assessment, or timing the amount of time it takes to walk from the scale to your room, and give you a sense of gait. So or there may be community health workers who can do a PHQ-4, or can ask, or do a loneliness assessment, or ask some of the questions before they see you, and then you can see the results. So to me, when you're starting with primary care, it's always resources that frame how you want to do something, but it's also needs, and you can, how do you get the buy-in by tying what you think is important to what your constituency thinks is important. And
I mean, I think,
yeah, go ahead.
Yeah, you're absolutely right. And I really liked the slide that you had when you talk about, so who would you do these screenings on? Would it be age-based? Would it be based on the resources you have, or the aspect that maybe that your clinic can focus on for that time being? And yeah, and resources is always the issue, isn't it?
We're still arguing over who should be brought in, who should be screened. And so sometimes that's left to the last. You decide, okay, we're going to do comprehensive assessment, or we're going to focus on brain health, or we're going to focus on gait. But that last question of who are we going to screen is sometimes the most malleable. I'll make one other comment, and that is that there are a lot of people who don't want to see a geriatrician, and we're getting this feedback a lot. Even in the SPNS program, the national program that the feds are funding, the people with lived experience who are working with us shocked me by saying, they don't want it. They're here in the SPNS program on HIV and aging, and they don't want to see a geriatrician because of what that means. So you, as a primary care provider, you get around that, but you have to begin with how do you frame this in a way that people aren't scared of the implications. I was told, don't call yourself a geriatrician, call yourself an aging specialist. So it's marketing the same way everything else is marketing. And how do you frame this in a way that demonstrates that you are concerned about what your patients are concerned about? And you're taking your expertise and you're broadening that a little bit because their concerns involve all of these things as opposed to what they thought it involved.
And I suppose also in primary care, you see your patients regularly as well. So that's not necessarily that necessity to have to attack everything all at once. And sometimes it's, as you were saying, it's identifying their priorities. Yeah. There is a question in the chat box, but I think that we could actually address it at the end after the case presentation, if that's okay. It's a comment from Andrew Tan from CLASS, a community-based organization in Malaysia, and he kind of shares about how he's recently had a back injury. And, he wants to know about how we can prepare people and support systems for this. And I think that question actually plays quite nicely into our case presentation that's coming up. And that way, then the panel can all kind of, weigh in with their expertise on that. But before we move on to the case presentation, can I just check whether anyone has any questions for Dr. Eugenia?
Hello, this is Grayson from Hong Kong. Hello, Dr. Eugenia. So, for these screening tests, do you repeat the screening for each individual at a sort of a regular interval, or would that depend on the results of your first screening?
I think that it depends on a lot of things. Absolutely the results. Screening is just that. It's looking for cases and looking for problems that are not obvious. So if you find that someone has one of these problems with functional capacity, then you switch from screening to intervention and assessment. So sometimes, screening is not necessary anymore because you have found it. But I think this is a question from primary care. I, as a geriatric specialist, often would not see the individual regularly enough to do the screening. In general, I think that you would probably find that if someone is free of the deficits that you're screening for, that a yearly annual visit is all that's necessary. But it also depends on the age. If you, for example, decide that everyone over 55 is eligible for screening, and someone is healthy and vigorous and working, it doesn't make sense to do the screen every year. Whereas if you start screening a 70-year-old, you're going to want to do it every year. This is why understanding your population and its needs is and identifying whom you're going to screen is to me one of the hardest parts, because you are not dealing with a uniform population. And it's also an opportunity to ask someone at the end of the screen, you know, how'd you feel about that? Would you like me to review those questions every year? Or, you know, if they said, you know, that was, I didn't think I needed that. That's for old people. Then you have a sense of what you need to do. But I think you know, as far as, again, if we were to look at what the United States suggests, then the Center for Medicaid and Medicare Services suggests a screen every year, but that's a population starting at 65. Your screen should be based on how close someone is to showing some deficits, what they feel about the screen, and your sense of how vulnerable they are.
All right. Thank you. And I think Han Young has a question for you as well.
Yes. Thank you, Dr. Eugenia, for your sharing. I'm particularly interested on the point you raised when you say you normally will discuss with the patient about goals in life. So I'm just wondering, in the interest of everyone here, how will you advise clinician doctors to start this conversation with the patient? And how interesting do you find this particular questions impact your plan in terms of working with the patient for a better outcome? Yeah. So those are questions from my end. Yeah. Thanks.
No, it's one I love to talk about, and I shouldn't talk about too much. We actually wrote about this. I didn't start asking, and it just, the conversation, you know, one of the things about CGA is that if you follow the check boxes, you're going to miss a lot, because the conversation that you have while you're doing a CGA is very rich, and it was in listening to what people were saying about their lives and the struggles they were having that got me to start asking about goals. The discussion about goals, what we found out was that 15% of people I spoke to in the first 100+ assessments I did, 15% could not articulate a single goal. They said, I have no goals. I can't think out of today. And that correlated better with depression than almost anything else. You know, that so there was the sort of the shock I had that the people could not think out of how to survive was a revelation to me, but also allowed us to talk about, you know, what do you need? So when we talked about goals, you know, to live, to survive, to be financially a little more secure, I don't have goals. What dominated, although there are others who had dreams of, you know, painting again. So the question about goals served two purposes. One was, you know, does this person focus so much on just survival that they need more support in the most fundamental way? And the second was, goals allowed me to ask in an indirect way what priorities were, what mattered to them. And, you know, because there are times that if you say, well, let's talk about advanced directives, and people would shut you off because they they felt you were either talking about dying or you were asking a personal question about whom they trusted. Goals was a way to begin to get into their brains about what mattered to them. And so it was for me, again, it was interesting to see the correlations, and it was a revelation to me about how deep the scars were. But what it was a trust gaining exercise and an opportunity to get to begin to understand what really excited them and what really troubled them, and you follow up because it's a conversation, it's not a checklist.
And, just adding to what you're saying as well, in the chat box, people have been putting in comments. So Fletcher from Taiwan has also mentioned how what they did was they started building awareness of aging issues, even when they're not aged already. Because I guess by creating that awareness, it also just, gets the wheels turning to get them to start thinking about, these goals as well. Well, thank you so much, Dr. Eugenia, for answering all of these questions and for your insightful talk. But please do continue to join us for the second half of the case presentation, which we're going into now. So do please keep your questions coming. And, to the Hub members also, if people are putting comments in the chat box, if you feel that you can respond to one of it, please go ahead as well. And so moving into the next part is our case presentation. So over the next 5 to 10 minutes, I would like to invite Dr. Ng Siu Tim, who is a specialist in infectious diseases in a public HIV clinic in Hong Kong. And he's going to present to us a case of aging with HIV for discussion. Dr. Ng, over to you.
Okay, so thank you. So let me share the slides first. Okay, so just let me know if you cannot see the slides. Okay, and so I'm going to start my presentation. So good evening, everyone. So I'm Dr. Ng from Hong Kong. So I'm going to present a case of an aging HIV patient. So, in this presentation, I will first give some background information about the patient, and then I will spend some time to present some issues that spanning over his journey of his HIV infection that we are going to discuss today. So our patient is a 67-year-old gentleman, and who was a Chinese ethnicity, and he's a non-smoker. His orientation is heterosexual, and he was diagnosed of HIV back in 11 years ago when he was in age 56. At that time, he presented with pneumocystic pneumonia and pulmonary MAC in 2013, and an HIV test was arranged and turned out to be positive. His presenting CD4 count was only 10, and the viral load is a 1,900,000 copies per mil. He was started on the antiretroviral treatment afterwards, and he responded well, and the viral load become undetectable, and there is also a recovery of the CD4 count. And the table above showed the ART regimen he had since he diagnosed with HIV until current. And overall, he have a good tolerance to the antiretroviral drugs. He also have a good drug adherence. And his viral load have actually remained suppressed since 2014 for around 10 years already. Apart from the HIV infection, he also have other medical comorbidities, including a hepatitis B co-infection, a fatty liver disease, depression, dyslipidemia, hypertension, and also coronary artery disease. The coronary artery disease was confirmed with a CT coronary angiogram. And he was last seen in our clinic in July this year, and the latest blood test looks quite good, with a CD4 count of 400 with a suppressed viral load, and the complete blood picture, the renal functions, the liver functions, and there are no growth abnormalities. And for the other blood tests, for the metabolic profile, he have a good cholesterol control with medications. He also have a good fasting sugar, and the calcium and the phosphate level are satisfactory. And for the recent radiological investigations, and the ultrasounds show a mild to moderate fatty liver, and a FibroScan was also done, and the results suggestive of some mild liver steatosis, and also there a probable minimal fibrosis. A chest X-ray, the chest radiograph show no obvious abnormality, and a DEXA scan was done, and the T-score of the lumbar spine was 1.6, and of that femoral leg is 0.3. And this is a list of his current medications, and he is on aspirin, atorvastatin, losartan, sertraline, and for the ART, he is currently on a combination pills of emtricitabine and tenofovir and lefenate, the TAF, and also a valtecavir. So let's move on to his functional ability. He's well coordinated with independent activities of daily living. There is some impairment of his vision, and he has no problems of hearing. For the nutrition, he is somehow at risk of malnutrition, and he has moderate decrease in food intake with some weight loss, and some mild dementia, etc. And for the quantitative assessment, and both the International HIV Dementia Scale and the mocker results are shown here, and it apparently have a pass in this cognitive assessment. And there are also some assessment of the mental health, and by the patient health questionnaire, and he have some mild depressions, and the DASS, the Depression, Anxiety, and Stress scales, also indicate that he may have some depression and anxiety, and also some stress. For his social history, he is currently divorced, and currently living alone in a renting private flat. He is retired, and the social support is limited as his daughter is living in the United Kingdom. And for his hobbies, he's suspected to have some hoarding at home. So, and that's for his background, and I'm going to present some issues for discussion. So, for the first issue, the first one is the recurrent fall. And he actually when he presented to us in 2013, he actually also reported increase in forgetfulness and unsteady gait at the time. And at the initial assessment, he has some weight loss if drinking beers 2 cans per day at that time. And the examination showed that there was some generalized muscle wasting with the limb powers reduced to a grade 4/5. And there is no cerebellar dysfunction or impairment in sensation on the initial assessment. And some workup has been done, and MRI brain have shown that there are some temporal atrophy and some hippocampal atrophy, which is compatible with some HIV-related changes. And a lumbar puncture was performed, and the opening pressures is within the range, and the CSF analysis actually does not reveal any abnormality. And a course of rehabilitation was offered during his stay in the inpatient, and he was discharged home afterwards. For the first few years after his discharge, he still suffered from some repeated fall, but his mobility have gradually improved later, and currently he is ambulatory without any difficulty in his activities of daily living. And for some, what we may discuss about this is that maybe we can see how could we have better support him at the time when he had the recurrent falls. And apart from the recurrent fall, he also have some urinary incontinence, and this is quite recent. In just this year, he actually start complaining of stress and urge incontinence, and sometimes he may have some accident that embarrass himself. And otherwise, he don't have other urinary symptoms. And we have given some different medications, and but either he do not tolerate or his blood pressure do not allow us to start further other medication. So maybe we may also focus on the discussion on how we may help with the patients with some urinary incontinence. So another issues he have is the visual impairment. And also start in this year, he also complains of worsening of vision on both eyes during the follow-ups. And he have seen an optometrist who told him that he have a myopia, but when he the vision was only partially improved with glasses, and the visual acuity is reduced on both sides when he was not taking glasses. A retinal photo was taken and showed some hypertensive changes with silver wiring and some AV nipping. And maybe we should also try to discuss what initial assessment should be performed, and also to see when should we refer the patient to an ophthalmologist in such case of visual impairments. And maybe that would be what I've prepared today for our discussion, and just feel free for any discussion and also some questions. So, and thank you very much.
Thank you, Dr. Ng. Can I open the session up to the participants and the hub members if you want to ask any kind of clarifying questions from the history? So there's a question from Dr. Julia. How is his proprioception of the lower limb?
In initial assessment, the coordination, the proprioceptions looks well. I think the only abnormality we noted is that there is some weakness. There's a grade 4/5, some mild weakness noticed during the examinations.
And can you talk about the gait a little bit more?
And for the gait is the so-called unsteady gait is quite non-specific in this patient. And yeah, we try to test the coordination and test the sensation, and actually we cannot identify any special patterns of the abnormal gait. Yeah.
And what is his current blood pressure?
The current blood pressure. So, and for the current blood pressure, so I did not make a copy of his more recent notes, but his blood pressure is currently well controlled on the losartan.
Okay, so it's well controlled at the moment. All right. And Ken is asking as well if you have the Z score for the DEXA scan.
That score, so I think only T score. I only have a T score right now.
All right. And Priti, the pharmacist, was asking whether his medication adherence was assessed and all, if it was assessed, how was it assessed?
So for the medication adherence, so we mainly focus on the ART in our clinic. So we actually, when the patient return to follow up, we actually will also see our counselors, and they will ask them how he take the medications. And in this patient, he does not have a compliance issue with his ART. Yeah. Yeah,
So I guess,
also,
yeah. So I guess that's something to consider as well. I think often as ID physicians, we tend to look at medication adherence as ART adherence, and we forget to ask about adherence about all the other medications as well. So that's something to consider. And maybe later, Priti, you can kind of maybe describe to us about how can we assess medication adherence. And I'll direct that question to you a bit later. And Dr. Julia has asked whether we have an MRI at all of the spinal cord because of the weakness and the urinary symptoms?
Spinal cord. So I think we so I think I reviewed the MR report. It do also mention the spine, and but it was there's no abnormality was told, but it was done quite some time before. So I guess it may be quite distant for the recently onset urinary incontinence.
Mhm.
Yes.
And I guess I have a question as well. I'm just wondering, way back when, about 10 years ago when he was diagnosed, did he have any CSF viral load taken at any point?
No, we just take do a routine number puncture, and the cell count was normal, and the microbiological workup was revealed, and we do not ask specifically for the viral load.
Yeah, I mean that's something to consider as well if someone is well suppressed and starting to have these symptoms, because I think you did do a lumbar puncture in the past as well.
It was quite distant, near when he presented.
Yeah, and I think Dr. Ken has a question. Was the patient asked what was worrying him the most at the moment?
So so the patient was actually called a follow-up by us, and also he was seeing the psychiatrist. Actually, one of the issues that he mentioned to us, and also the psychiatry, is that he is renting a flat, and he is actually sometimes has some conflicts with the landlord and about his flat. And sometimes the landlord may complain that he brings too many things to the house, and this is one thing that may cause him having some stress, or having some anxiety. And I think this is quite a issues for him. This is quite issues for him, and he mostly mentioned to us.
Yeah. I think that answers Dr. Julia's question. And Dr. Jenny also mentioned that if there is financial stress, if we haven't asked about it, patients often pick and choose which prescriptions they fill, and they will only usually fill out their antiretrovirals and not their other medications. But can I invite everyone, feel free to unmute yourself and ask these questions. You don't have to put them in the chat box for the hub members, because this is like a open discussion. Yeah. So Sister Cheng Hong, I see your question and that you've joined us. Would you mind introducing yourself and then maybe asking your question?
Hi, good evening. I hope you can hear me loud and clear.
Yep.
Okay. So thanks for presenting the case. I think it's quite an interesting case and evolved quite a number of common geriatric syndrome we see in our PL-HIV. So my question was whether the fall, because I know there's a recurrence fall. So usually where does this fall happen? Is it at home setting or in the community? And usually is it in the early morning or at night? Is there any pattern that we noticed?
Actually, we don't aware of any special pattern of his fall. Yeah, he just have some unsteadiness and just have the falls. Yeah.
Okay. Yeah, thanks for the clarification. I also noticed that he also used to drink 2 cans of beer per day. Is this still happening currently? Like, is it like?
Is he still taking alcohol?
Yeah, I think in the recent few years, when he compared to us, he just report he's a non-smoker and non-drinker. Yeah, but this is what in the recent few years. But when we dig back into his notes when he present to us, we found that he also drinking some beer. When he presents, when we dig back to his past medical records.
Understand. Yeah, thank you. Do we have any sarcopenia assessment for this patient? Like, whether in terms of physical performance or muscle strength.
So strange. So I'm not aware of that. Okay.
Maybe that's something that we can touch on as well in the discussion. So if that's okay, actually, I'll start to direct the discussion and the conversation to our geriatricians. So Dr. Kajal and Dr. Wirasak, I was wondering if you could share with us how we might approach this patient with falls. Of course, a lot of our hub members have already, asked all sorts of questions to clarify a little bit more about the case, but maybe you can help just to break it down for us a little bit more.
Okay. When we usually when we find some people with recurrent falls, we approach as intrinsic and extrinsic cause of the falls. For intrinsic is maybe from nervous system or from the musculoskeletal problem or blood pressure, low blood pressure, or medication induced, and so many other causes. And for the extrinsic causes, I think from the question that everyone try to focus. But in this patient, I think because he has bilateral lower legs weakness, which occur with the weight loss. So the first one for bilateral weakness, we usually think about myopathy. Myopathy actually should affect the upper extremity as well, but the large muscle usually are affected first. So the large muscle of the lower leg, for example, the proximal muscle weakness usually affected first. So myopathy, the cause of in this patient, because the symptom was accompanied after the weight loss. So the first one is sarcopenia. Usually we should focus on the sarcopenia, which can be reversible if we improve the ambulation and nutrition supplement. And the second thing that can be reversible that cause the myopathy is about electrolyte or metabolic cause or drug-induced myopathy that we have to focus on, that we try to ask about the medication or medication interaction, drug interaction, something like that. The other two causes that can cause bilateral lower leg weakness, but I don't think that the symptoms are compatible with this patient. The other two causes is the spinal cord conditions or a neuropathy or radiculopathy, which can cause the bilateral weakness, but usually the symptom cannot be recovered or improved by medication or rehabilitation. And the other cause is in the frontal lobe or the hydrocephalus. People with hydrocephalus, sometimes they have bilateral gait problems or bilateral at the frontal lobe problems. But because this patient, he got the MRI scan of the brain and it showed the report of no hydrocephalus at that time. So I think, and no focal lesion at the frontal lobe from the presentation. So I think spinal cord, radiculopathy and frontal lobe lesion hydrocephalus can be, I think, should be excluded. So the main focus is about the myopathy, which can be from muscle loss from sarcopenia, nutrition problem in this patient. I'm not sure,
Dr. Weir,
Keshal, you have
Can I interject and maybe either Kajal or yourself, Dr. Wirasak, can maybe elaborate a little bit on this. So earlier on, Sister Cheng Hong asked about sarcopenia. And so sarcopenia is a new concept to some of us, especially those that may not be in the, the aging field. So I was wondering maybe either Dr. Wirasak or Dr. Kajal, you can tell us a little bit about sarcopenia and what you mean when you talk about sarcopenia assessments.
Hi, so maybe I can jump in. So sarcopenia, just from the term sarc, muscles, penia, loss, just means loss of muscles. And it can happen acutely when people get admitted. So going back to the story when he presented with that OI symptoms, and then he was having repeated falls. Maybe he had lost extreme, he had extreme loss of muscle bulk, and that caused him to fall, which then got better with rehab and nutrition and as we treated his infections. Actually, there are many different screening tools on how we can actually just ask for sarcopenia or even screen for sarcopenia. But a quick one would actually be when we are doing the CGA, like Dr. Eugenia mentioned, even just simple questions about the mobility would be quite helpful. So there is a screening tool which I like using, especially in busy clinics, is SARC-F. We'll share the screening tool, SARC as in SARCF. So SARC basically, this is 5 questions that you ask them. One is strength, simple questions that you have troubles lifting about 4.5 kilos of stuff. And that's quite easy, especially those who have got grandchildren. You ask them when you're lifting them, do you have troubles? You could lift them now, previously, and now you can't. Or even simple things like, carrying things of their own household stuff. So that's their S. A is ambulation. So can they actually just walk across the room with or without any troubles? Hold on, I forgot assistance. Do they need any assistance when they're walking across the room? So that's the A part of it. The R is rise. Again, going back to a little of part of the CGA when Dr. Eugenia mentioned where you can do a sit to stand. So do you have troubles getting up from the chair? And C would be, how much of troubles do you have climbing the stairs? So all this need not be directly saying that, oh, I want to do a sarcopenia screening. Actually, when we were doing the CGA and they say that, oh, I'm having troubles, now even walking up the stairs is becoming more challenging, even walking across the room, going to the toilet becomes more challenging. So that can already give us some clue, and then you can prompt from there further up. So that is basically the SARC-F screening. So sometimes a quick thing when we do for awareness is basically we ask them to do, I forgot the name of the test, I'll share with you. If you ask to do using your index finger and your thumb and you try to connect it, and you then put it at your cuff, at the largest diameter of your cuff, and you try to see whether you are able to go through. Is it crossing? Or is it nicely reaching out? If you're able to, just nicely, then it just gives you a rough idea. This is just rough. It's not a detailed sarcopenia screening, but it just gives you that, okay, your muscle bulk is not adequate enough. Just that. There's a name for this test, actually, which I can't remember of.
I think everyone's sitting at their desk trying to do that now.
Yeah.
That's really great. Yeah. And I guess, so going back to their questions, I know the focus on the discussion was about falls, but, they also mentioned about, vision and incontinence. And I think all of these things can really contribute to falls as well. So if you are going to, so if I were a primary care physician, ID physician who's not familiar with aging, apart from the SARC-F, how should I approach falls?
So I think when we're talking about falls, we just need to understand what are we looking at. There are 2 ways. One is you're looking at people who have had already fallen, community dwellers who have had fallen, and you're trying to look for risks or the reason of why they fell. And this is usually multifactorial. It's never one reason. Often there's many reasons: hearing, cognition, environmental, poor hearing, poor walking aids and all that. So this is one group. The other group is your routine, regular patients who come up to your clinics and they are aging, or you want to start screening them. Are they high risks for falls? So 2 different groups. Let's just talk about the latter first. So if you're trying to screen for people who you think may or may not be at risk, so the recent Weill guidelines, Weill Falls guidelines, which should be also uploaded into your resources, has got just 3 key questions. You can even drop it down to 1 question, to be honest, but basically asking them, have you ever had a fall in the last 1 year? And when they tell you yes and no, that you can then probe further to ask where did the falls occur, how did it occur, is it indoor, outdoor, because that gives you really an idea of the severity. Was there injuries? Was that a syncopal attack and you got up? And even if the injuries, was it just a trivial, just a bit of bruises here, or you actually sustained some fracture? So that tells you the severity bit of it. Just 1 question, have you ever had a fall? Second thing is, have you noticed any troubles with your balance when you're walking? So often patients will tell you that, oh yeah, in the last 1 year, I find it a bit difficult. I'm also so worried I might fall. So just this 1 or 2 questions already tells you that, okay, my patient is actually at risk of falling. And if they then tell you that I've already fallen, it's those patients that you will already now start flagging, basically doing a comprehensive geriatric assessment, head to toe, trying to figure out what could be potentially the reversible cause that you can prevent him or her from falling. Let's start from the brain. Basically, it's actually cognition. We know people with cognitive issues are at higher risks of falling. So just a quick gait assessment can give you an idea. Vision, hearing, vision as well as hearing, and then you go down. So every system affected, meaning doing a thorough assessment, would give you an idea. So when you already have someone who has fallen, your aim is to figure why they fell and how you can prevent them from falling. Someone who has not fallen, your aim is to pick up who is at high risk and how can I intervene early so that he doesn't have a fall.
I guess, and when you were talking about evaluation for people who've had falls, you were using, you're kind of following something similar to the ICOPE domains as well, isn't it? Cognition, vision, hearing. So just by asking those simple things, it also provides us with the areas that we need to focus on to then focus our management on it.
Correct. So all these are the intrinsic bit of it. There's also the extrinsic bit of it, like the environmental things. People don't realize, especially like this patient was hoarding at home. Maybe his house itself has a lot of environmental hazards for him to fall indoor.
Okay, thank you. And feel free to add your questions to the chat box. But while we're waiting for questions, can I also ask Jenny and Grace maybe to comment on his HIV management?
I guess looking at this man with an HIV lens, an antiretroviral lens, someone who has falls, recurrent falls, I worry about fractures following those falls. And if you look at his antiretroviral medicine for the first 5 years of his treatment, he was on tenofovir disoproxil fumarate and ritonavir boosted atazanavir, which probably is the greatest cause of the greatest amount of bone loss. After starting antiretroviral therapy, you'll lose about 6 to 7% of your bone mineral density with that particular regimen. When you switch the tenofovir disoproxil fumarate to tenofovir alafenamide, you will gain some bone mineral density, but you don't regain the 6% that you've lost. You only regain about 2% of that bone loss. So I was actually really surprised to see the results of his DEXA scan, because that was a really respectable DEXA scan. So I can then go back and say, okay, I don't need to worry about it in 2024. But if I had a choice of antiretrovirals back when we started, and he was already having falls, I might have chosen a different regimen and probably would have tried to get a DEXA scan at that point in time.
Yeah, because he was probably he was 57, isn't it, at that time when he was diagnosed. And Grace, do you have any comments?
Well, I actually have been seeing this patient, so I think the reason why I put up this case is mainly to find a person with multiple geriatric syndromes along the whole course of journey. So I guess I'm really trying to learn from everyone. And
Sure.
in terms of the fall, I really appreciate what Kachel and Dr. Wirasak has mentioned. I think as ideal HIV clinicians, it's sometimes very hard for us to approach a geriatric issue. And I guess the approach or the framework that you've mentioned, how we assess the intrinsic and extrinsic factors that would account for the fall, that's actually how they put it makes the whole situation simpler. So for us, it's the geriatric syndromes are all these giant syndromes, which are very difficult to manage in the clinic. But when we do have an approach, I think we actually can systematically manage these issues in our clinics.
Thanks, Grace. Can I direct the questions now to Ken and Harzana? Just, if you can share with us how you would have approached this patient in primary care.
I might jump in. So this is a complicated patient. I think everyone agrees with that. And I'm so glad that people are mentioning primary care in this, but it's certainly not a scenario that we're going to solve everything in one go. I think what Dr. Siegler said is that this is going to take time and sorting out. So I kind of see my role more as working with the patient to work out the primary concerns, what's important and how I should tackle these, and be more like a care coordinator than the fixer of things, other than the basic primary care things, to try and maximize his medical management as best that I can, and then refer on. Probably my first referral would be to my local friendly geriatrician to do the comprehensive geriatric assessment and to come up with the overall picture of what's going on. But often these sorts of cases, I try and get everything I can, like the case has been presented, and then I try and step back and look at it through a biopsychosocial sort of lens and break things down into the different sections to know how I'm going to tackle the different problems and who I have to bring in to the team that I have access to. We're lucky in Australia, I guess, because we have access to all these allied health colleagues who can help and assist, whether it's in the public or the private. I know every country is different in terms of how primary care is set up and how people with HIV receive primary care. So you have to work within your setting. But this is a very complicated scenario. It'll take time to sort out.
But I really like what
you
you
can add an insight from the Malaysian system.
Yeah, that'd be great. Where is Razana?
Hello, everyone. Maybe
hi.
Yes, because I just look into the WhatsApp, the chat box, as well as actually mentioned a lot about the primary care physicians' roles. So basically, elderly healthcare in Malaysia was started 30 years ago. It's around 1997. I just give an overview of elderly healthcare in Malaysia, especially for the primary care first. Then I talk about the case. So at that time, our elderly healthcare is actually as expanded scope, and majority of the cases that being referred to us is actually non-communicable disease. So I think now when this ICO project is actually being done, so I think this is actually great networking with the ID physician, because recently we in Malaysia, because now we actually a growing numbers of FMS who actually have interest in geriatrics, about 20 FMS in the government setting, in academia, as well as in a private. But then I know this is actually not enough, okay, as we are actually facing to aged nation in 2030. It's actually not that long. So yeah, so it's actually our Ministry of Health under elderly healthcare sector is actually have done a lot of meetings and discussion a lot on these issues. So we are actually have growing awareness about the aging issues. But then towards this special group population is actually, this is actually the starting. I think this is a great opportunity for us to link up. Yeah. And regarding the case that we have discussed just now, if the case is actually coming to my clinic, as you all know, I mean, I have this geriatric, I have opened up dedicated geriatric clinics in my community setting in a Pandamaran Health Clinic. So it's actually since 2020, yeah. So majority of the cases that I'm seeing is actually NCD case. So if the patient is actually coming to my clinic, I know this is very complex case. It's not easy to settle in one time. And usually most of the time I will see this patient roughly around 1.5 hours with the caregivers. not long that yeah. And so most of the time when I see this patient is actually multidisciplinary teams will be in one setting, meaning that when the patient come registered to my registered, and then after that the assessment will be done by the paramedics. So it's actually including the blood pressures, lying down, standing, at 0 minute, 1 minute, and 3 minutes, because we want to see the postural hypotension. That's actually maybe the reason why the patient have fall. We don't know. Yes, okay. And apart from what you call that measure, check the visual, the hearings, and then we also check the ECG as baseline when the patient lying. And then of course after doing that, the patient is actually will come to my room, and we will do the CGA, Comprehensive Geriatric Assessment. And I do agree, we actually use that I cope approach. It's very easy and very simple and very concise. And I have trained some of my MOs in doing this, and then they actually quite competent. And then of course in terms of cognitive, we have to use the specific specific tools lah. So either mini-cog, MMSE or MOCA, depending on the things, it depends on the time that we have. And then if this patient is actually need to be referred to physiotherapist, since this patient have a lower limb weakness, so of course for the what you call that, maintain the balance and strengthening to the avoid further falls and so on. And yeah, and then in terms of continence, that is actually another thing. If it's not easy to settle, we have to find out the root cause. Yeah, so I usually like to do some diary, the bladder diary. Yeah, just ask what is actually he's been drinking. And then the frequency of his incontinence, and then the types. How is actually he's having all these incontinence. We want to find out the root cause. Yeah, and in terms of he's also having some malnutrition issues. So yeah, we refer to dietitian to do some assessment and do further intervention and how we could have. And yeah, so basically we're not doing this alone. It's actually multidisciplinary approach. And if we cannot do in one time, usually there will be follow-up, and we have a multidisciplinary discussion to and then everyone will update what is actually their plan, and we have to come in a one setting a common goal for this patient. So basically we try to help this patient in a holistic way, and to improve their quality of life. Yeah.
I think that's really great in terms of the services that you've been able to set up. And I think on another occasion, or over the next few months, as we hear more from you, we'll be able to hear about how you've managed to engage the different stakeholders to build that multidisciplinary team in primary care, as you've done. Thank you so much. And I know you also mentioned about physiotherapy and things like that. And I'm just wondering whether I can ask Dr. Julia and then Kenneth as well to talk about what potentially we can do with rehab medicine in tertiary care. And then I think, Kenneth, you do a lot of work in the community as well.
Okay,
Right.
hello. I mean,
Yeah,
okay,
so
maybe
you
I
can,
can
yeah.
say something first. Yeah,
Yeah.
I have quite a strong feeling with this case because I also in Hong Kong. Okay, so and actually I got like quite a lot of questions about this case. And first off, the question will be about the why this case will fall in the past. How did it happen, and the frequency of the fall, because that makes a huge differences of the management. For example, if the this case fell on the street outdoor, or he fell on at the home, because if this case fell in the street mainly, that means they may have the poor muscle power or poor endurance. He cannot walk for long distance. Or if the case fell at home, that may means that the environment at their home may be not very suitable for ambulations. But in Hong Kong, most of the people live in a tiny little space. And I'm sure that we can find some cues if in the home. And usually if this case is presented to my clinic, usually I will do some home visit to see the home environment first. But of course, the cause of the fall will be an important issues. Another thing I would like to ask is about the unsteady gaze, because unsteady gaze is quite non-specifics to me. For the gaze analysis, we can do a lot of things to analyze why this case fall. For example, if the case got the poor hip flexor strength, for example, when the case swing the leg forward, if the hip flexor is not strong enough, the foot clearance may be quite poor. So if he's walked in the outdoor environment, that the poor foot clearance may kicking something that may cause the fall. For example, if the case also got poor in ankle dorsiflexor, that means they also affect the foot clearance. That these factors that may also affect the fall risk, which we need to do some detailed gaze analysis to see whether this is a swing problem or a stand face problem. And another thing to me will be the muscle power. So in the documentations, I noticed that the muscle power is grade 4/5, right? So 4/5 to me is not bad already, because a lot of the elderly got 4/5 should be quite normal. But one of the missing part of that will be the muscle power does not tell us the endurance. The patient may have a very good power in the first 5 minutes, but he or she may be very tired after the 5 minutes. So we may need to know more about the endurance, how far or how long the patients can work with. For example, the patient might be very stable in the first 5 minutes in walking, but the patient may become unstable in the next 5 minutes. So that will be better to do, for example, some 12 minutes walk, or do some walking tests to assess the endurance of the case. And the MRI brain shows some cortical change also that may also affect the motor control, maybe. And in general, even for this case, I see that the case is walking unaided now. So that may think that for short distance walking may be okay, but I very suspect that for long distance walking, that may be the problem. But I still need to discover more. So in our physiotherapy practice, usually we will do some standards tests, and we will also do a lot of the balance tests. For example, in Hong Kong, we usually do the bird balance scales, BBS. We can quantify the ability of the patients to see which component of the balance is being affected. And also we can do time up and go, functional reach, and something like that to find out which part of the balance is having the problem. And then we find out the problem, and then we treat that problem. For example, if the endurance it's the problem, so we do some endurance training. If the hip flexor is the problem, we do some hip flexor training. So in this case, the patients improve after inpatient rehabilitation. That means it actually responds to exercise. But the problem is usually when they discharge back to home, due to isolations, not outgoing, and then the physical fitness will decline. So that is a quite common problem. So I will suggest that if we can link this patient with some NGO or some community center so that we can continue the exercise or rehabilitations in the community setting, that will be better. And also this case seems isolate himself at home, not many friends and family, and perhaps we can introduce him some social worker and introduce some social activity so that he may have more outdoor activity. Yeah, so a lot of questions. So
Yeah.
I would like to share about this. Yeah.
I really like the idea of encouraging more of these exercises and these social interactions within the community organizations, because I think that as people are getting older, as you rightly said, right, in the hospitals they might do your exercises, but once they go home in the community, if they have no avenue to go for these exercises, if they go to a gym, they might feel a bit self-conscious. So having it in the community organizations, I think is a great way to approach this. Thank you. Dr. Julia, do you have anything to add?
Right. Thank you. So I spoke a lot of on many of the issue that I agree on. Basically, there are two things. First is that when you say muscle, MRC of 4/5, normally have rehab physician. I'm not happy because what is 4/5? And people usually underestimate the role of pelvic girdle muscle in walking stability. So a lot of people do not examine the hip abductors, hip extensor. It's mainly all those hip flexion, knee extension flexion, but do not do a detail. So I mean, it's very important to do a detailed assessment of all the muscle, right, from the pelvic muscle, girdle muscle, that's one. And number two is that when you examine static of 4/5, when you ask the patient to walk, it might not translate that it's okay, because when you walk, there are a lot of coordination between all the muscles. So like Kenneth mentioned, it's very important to actually do a functional test, not just, walk across the room and you're okay, but do it a bit longer, because when you, in your day-to-day activity, you do walk more than just a few meters. So thanks, Kenneth. So that's all I want to add. Thank you.
Thank you, Dr. Julia. We have maybe another 10 minutes left, but I do want to ask Priti or Tuankan to maybe comment a little bit about medication adherence assessments and also, the antiretroviral choice in this case.
Hello. Yeah, so as a pharmacist, I was looking mostly on the drugs. And so at the initial phase, I looked at the recurrent falls, and I think a bit of task shifting probably can be employed here, where patient could be given some fall precaution counseling or education, which is external things such as, especially since the patient has been noted to have a habit of hoarding, and also regular medication reviews, medication reconciliation. There's a method called the brown bag method, whereby the patient just brings all the medications in a bag and is reviewed by the pharmacist. Also in our hospital, we also employ the home medication review. We have a home medication review team to go and look at selected patients. And this could be another method that we can also assess patients' adherence. Prescription records is another method that we can assess. There's also a scale called the drug regimen unassisted grading scale, which is used to measure patients who are elderly in terms of their adherence, and it's to measure their ability to take the medications independently in terms of identifying the medication, assess of the medication, the dosing, as well as the timing of the medication. So these are some of the strategies that can be employed. I also looked at the drugs that the patients are on, that this patient is on, and so I saw that the European expert group, the European Geriatric Medicine Society, has come up with the fall risk increasing drug, and it has been stated that fall risk increases with even just one one of the listed drugs as part of the patient's regimen. And I noted that the patient is on sertraline for his depression. And I think it would be good to ask the patient if he had any side effects from the drug, although I noted that it's a low dose, if he's experiencing any CNS side effects from the drug, such as somnolence, reversal sleep pattern, any drowsiness or giddiness. And these experts have also mentioned that withdrawal of these antidepressants have actually seen improvement in recurrent falls. So I would like to have an opinion from the geriatricians as well about whether a stepwise withdrawal or withdrawal of this antidepressant would be beneficial for this patient.
Thank you, Preeti, for that. In the interest of time, though, because we have overrun by a little bit, and I do apologize for that. Maybe we can carry on this question into the next session and address it in the next session, if that's okay. So I do apologize to Duncan and Sister Ching Hong, as I don't think we will be able to get your comments for this round, but hopefully we'll be able to do so in the next session. And I do apologize for that. If there are no further questions in the chat box, I will hand over to Norman for any housekeeping announcements.
Sure. I previously have a list, but I'm just going to point out the main announcements. So certificates will be sent out specifically for each session. We do admit that there are some logistic issues with different countries at getting CBD points. So we're going to send out each certificate so that you can then subsequently process the CBD points in your own respective countries. Again, resources will be uploaded, and here are acknowledgements. Next session, we'll have a very exciting session on addressing psychosocial needs of older people with HIV. It's going to be led by Hola Ping, who is based in Singapore. Apart from that, you notice that we don't have a translated caption in today's session. We hope to get it in our next session to ensure that our sessions are equitable for everybody, especially for individuals whose primary language is not English. So we hope to keep you posted, and if you could invite more people, especially from community members, to be more involved in this session. We do welcome everybody, and we mean everybody to learn together with us. With that, do keep in touch. If you have issues around the iEcho platform, do not hesitate to reach out to us. I guess that would be all. Thank you so much.
Thank you so much, Norman. And thank you to our hub members, our speaker, Dr. Eugenia, and to all of you here who have attended. I hope you are able to take away something from this and for your practice as well. Thank you very much. All right. Thank you, everyone. So we'll be ending the session. Have a good evening. Thanks so much.
Bye-bye.
Bye.